The laboratory picture of iron deficiency anemia is consistent and recognizable once you understand the logic behind each finding. Start with the complete blood count. Hemoglobin falls because there is not enough iron to build hemoglobin molecules. Hematocrit falls because there is less hemoglobin-containing material in the blood. The red blood cell count drops. The mean corpuscular volume, MCV, decreases because red cells being produced without adequate iron end up smaller than normal. And iron saturation, which reflects the percentage of transferrin-carrying iron, falls because there is less iron available to load onto the transport protein. When you look at the peripheral blood smear, the red cells appear hypochromic, meaning paler than normal, and microcytic, meaning smaller than normal. These morphological features directly reflect the lack of hemoglobin being packaged into each cell during its development in the bone marrow. The cell is small because it did not have enough building material to reach its normal size, and it is pale because it is not fully loaded with hemoglobin. Moving to iron studies, serum iron drops while total iron binding capacity, TIBC, rises. To understand why TIBC goes up, it helps to think of it with a simple analogy. Imagine TIBC as a bus with a fixed number of seats. Iron is the passenger. The protein transferrin is the bus itself. Normally, not every seat is occupied. When iron deficiency develops, the body responds by producing more buses, more transferrin, because it is essentially trying harder to capture whatever small amount of iron is circulating. TIBC measures the total seating capacity of all those buses combined. So when TIBC goes up in iron deficiency, the body is sending a clear message: I have lots of empty seats and not enough passengers. This is critically different from what happens in anemia of chronic disease, where the body intentionally reduces the number of buses, keeping iron locked away as a protective inflammatory response. More on that when we reach the differential diagnosis. The red cell distribution width, RDW, is also elevated in iron deficiency. This value reflects how much variation there is in the sizes of red cells. In iron deficiency, cells of very different sizes are being produced, which drives the RDW up. This can be a helpful distinguishing feature when comparing iron deficiency to other microcytic anemias. Now, iron stores themselves. The most sensitive single marker for depleted iron stores is serum ferritin. When ferritin is low, iron deficiency is essentially confirmed. However, ferritin has a critically important limitation: it is an acute phase reactant. That means any inflammatory process, infection, autoimmune disease, chronic kidney disease, malignancy, liver disease, causes the liver to produce more ferritin as part of the inflammatory response. In a patient who is both iron deficient and inflamed, ferritin can appear falsely normal or even elevated.